Now let us discuss one more important topic, that is varicose vein. First of all, we will discuss what is varicose vein, then what is the pathophysiology behind formation of varicose vein. It is mainly based on two pathology. One is perforator incompetency and incompetency in saphenofemoral junction. Now how to do the clinical examination? There are total 4 tests. One is Trendelenburg test, Perthes test, Fagan's test and Swartz or TAP test. Now what investigations we need to do and how to manage. Now some anatomical or theoretical topic. What are calf pump? What is the course of long saphenous or great saphenous vein? What is the femoral triangle and its importance and all? Saphenous opening, adductor canal. What are the methods of palpation of femoral pulse? And 3 types of claudications. Now let's begin. What is varicose vein? Varicose veins are dilated, elongated and tortuous superficial vein, most affecting the lower limbs due to valvular incompetency and venous hypertension. Now what is the pathophysiology? First is valve incompetency in superficial, deep and perforating veins. It is mainly seen in that the superficial veins, from superficial vein blood goes to the deep vein through the perforators. Now if the perforators are incompetent, retrograde flow takes place from the deep vein to the superficial vein and causing engorgement of the superficial vein, which is known as varicose vein. Now retrograde flow can also occur due to incompetency of the saphenofemoral junction. Normally from the lower part of the leg, blood is drained in the upper part, that is femoral vein. But if it is competent and blood comes from the femoral vein to superficial vein, that is the great saphenous vein, then it can become tortuous, leading to varicosity. Now what is primary varicose vein and what is secondary varicose vein? Primary varicose vein is idiopathic and due to weakness of the vein wall or valve. Secondary varicose vein due to other pathology like deep vein thrombosis, arteriovenous fistula, pregnancy or tumor. Now what is perforators? I have already told you that perforators are valves which prevent the flow of blood from deep venous system of leg to the superficial venous system, and it allows one-way conduction, that is from superficial to deep. Now how to remember the names of the perforators? I remember it like this, that is H, D, B, C. H for Hunterian perforator in the mid thigh, D for Dodd's perforator above the knee, B for Boyd's perforator below the knee in popliteal fossa, and Cockett's perforator in the medial lower leg. It is divided into 3 groups, that is upper, middle and lower. Now let's start the clinical examination tests for varicose veins. First is inspection and palpation. We inspect the what is the actual site of varicosity and how it is looking like, exact course, whether any ulcer is present in leg or not, whether hyperpigmentation is present or not, this if ulcer present, whether it is discharging or not. We can progress like taking the history of the ulcer, like what is the actual site, onset, progression, what is the number of ulcers present, and whether it is discharging or not, whether pain is associated or not, like this. Now varicosity may leads to ischemia and necrosis of the leg. We have to take find it in the inspection, like this. Now palpation. In palpation, we palpate the varicose vein, and in palpation itself, some tests comes, like first is Trendelenburg test. In Trendelenburg test, we assess the saphonofemoral junction incompetency. First, the patient is laid down in supine position. Leg is elevated to drain all the bloods from the superficial vein, and the vein is ultimately emptied. Next, tourniquet is applied in the thigh and patient is asked to stand up. If the vein fills rapidly before moving the tourniquet, it is incompetent perforator, and if vein fills after the tourniquet is relieved and it is very fast, then it is saphonofemoral incompetence. In Perthes test, we check deep venous patency, like whether DVT is present or not. In this test, we apply tourniquet in the mid thigh. In this way, we occlude the saphonofemoral junction. Now, if varicosity is emptied, then the deep veins are patent. And if varicosity is engorged, then deep veins may be obstructed. Next is Swatch test. It is also known as tap test. We tap the varicosity and palpate the impulse proximal to it. If tap test is positive, then it is like normal. Fagan's test, we locate the perforator first, then apply pressure at suspected perforator, and if the vein collapse, it is incompetent. Now let us discuss what all the four tests and summarize it. First is Trendelenburg test. In this test, we first makes the vein empty by elevating the leg, then apply tourniquet. In application of tourniquet, the saphonofemoral junction is occluded. Then the blood cannot go from the superficial vein to the that is femoral vein. Now, if the vein is filled immediately, then it indicates perforator incompetency, because the blood can come from two sides. One is femoral vein and one is deep vein. As the saphonofemoral junction is occluded, it is evident that blood is coming from the deep vein and perforators are incompetent. If immediately after the removal of the tourniquet the veins fills, then it indicates perforators are okay, but the blood is coming from the femoral vein. It is saphonofemoral junction incompetency. In Perthes test, we apply tourniquet in the mid thigh. It occludes the saphonofemoral junction. Now, if the varicosity, the patient is asked to walk. If the varicosity is emptied, then it means due to walk, the calf muscle has pumped and the blood has gone from the superficial vein to the deep vein, and the perforators are competent, and the deep venous system is also patent. That indicates there is no DVT or occlusion in the deep vein. But if varicosity engorges, that means the blood is unable to go from the superficial to deep vein, and some pathology is present in the deep vein. In Swatch test, we palpate the transmitted impulse proximally. And sorry for the mistake. Previously I told that if the test is positive, the valves are competent. It was incompetent because if we tap and the blood should naturally go from superficial to deep vein and not from below to upwards. But if it go from below to upwards, then it is retrograde flow and it is not normal at all. In Fagan's test, we locate the perforators first. How to locate? If the patient is allowed to stand on the leg, we are going to examine the site of the perforators will show bulge. We will mark those bulges. Then we will apply deep pressure on the site of bulge. What happens? With deep pressure, the perforators are closed. Now the bulge should not diminish. As the perforators are closed, the blood cannot go from superficial to deep vein and the ballooning remains. But if the ballooning vanishes, then it indicates perforators are incompetent. We have already discussed the interpretation, so I am skipping it. Next is investigation. We may do duplex ultrasound, Doppler plus B mode, and also plethysmography and venography to detect the pathology. Then how to manage it? Non-surgical management, compression therapy. This is routinely done in OPD basis. Leg elevation can also help. It is a home remedy. Exercise and weight management, it is general management. Avoid prolonged standing. Actually, prolonged standing is a pathophysiological factor responsible for varicosity, so it is seen in traffic police, bus driver, etc. Topical care of the eczema or ulcer, and pentoxifylline may improve the ulcer healing. These are symptomatic management. Now, what are the surgical or interventional management? It is ligation and stripping, endovenous thermal ablation, laser and radio frequency ablation, foam sclerotherapy, and phlebotomy. Now, what is peripheral pump? The most important is calf muscle pump we are going to discuss here. It is gastrocnemius muscle. Whenever we walk or stand, gastrocnemius muscle contracts, and due to this contraction, blood goes from superficial to deep venous system through the perforators. Next, let us discuss what is the course of the long or great saphenous vein. First is origin. It originates from the medial end of the dorsal venous arch, and it receives blood from the medial marginal vein of the foot. In ankle, it is anterior to the medial malleolus. In leg, it runs up in the medial side of the leg and medial border of the tibia, posterior to it. Knee, it is posterior to the medial condyle of the femur. Thigh, it is medial aspect of the thigh, and ultimately it terminates in the femoral vein. Perforates means crosses the cribri from fascia and the saphenous opening. What are the tributaries? Superficial epigastric vein, superficial circumflex iliac vein, superficial external pudendal vein, anterior and posterior accessory saphenous vein. Now, course of this vein is very important to locate the varicosity, position of perforators, etc. Now, some theoretical points may come in Viva table, like what is femoral triangle, its boundary. Superior boundary is inguinal ligament. Now, somewhere here it is pubic tubercle, and here inguinal ligament is present. It starts from the pubic tubercle to the anterior superior iliac spine. Next is medial boundary. Medial boundary is formed by the medial border of the adductor longus, and lateral boundary is formed by the sartorius. So here is inguinal ligament. Here is the if it is the right leg, here is the sartorius. This is the femoral triangle. Now, what is the content? From lateral to medial, nerve, artery, vein, and lymph nodes. What is the name? The lymph node of Cloquet. And name of the artery and vein are as such: femoral artery, femoral vein. Next is femoral canal, and next to it is lymphatics. The femoral canal contains femoral nerve. Next is femoral canal. Anterior boundary is inguinal ligament. Posterior boundary is pectineus muscle, that means it lies on pectineus muscle. Medial boundary is lacunar ligament and laterally is femoral vein. In the previous case, we have already discussed that the sequence is from lateral to medial, nerve, artery, vein and lymph node. So here is vein, here is femoral canal, and so lateral to it is present the femoral vein. It lies on the pectineus muscle and medially lacunar ligament is present. What is the content? Lymph node of Cloquet we have already discussed, like this. Next is clinical significance. It is very much significant in case of femoral hernia. The next topic would be the femoral hernia we will going to discuss. Next is saphenous opening. It is a oval opening in the fascia lata about 3 to 4 cm below and lateral to the pubic tubercle. What are the contents of the saphenous opening? Great saphenous vein. As it is very much evident, we are discussing the course of great saphenous vein and it joins the femoral vein in after passing through the saphenous opening. Superficial epigastric, circumflex, iliac and external pudendal vein. Next, what is the significance? It is the common site of varicosity and covered by cribriform fascia. What is adductor canal or sartorial or Hunter's canal? The boundary is anterolaterally vastus lateralis, posteromedially adductor longus and magnus, and roof is formed by the sartorius muscle and subsartorial fascia. What are the contents? Femoral artery, femoral vein, saphenous nerve and nerve to vastus medialis. What is the significance? Femoral artery becomes popliteal artery after passing through the adductor hiatus and site for saphenous nerve block. Here is some anatomical landmark for palpation. Where to palpate the femoral artery? It is palpated in the mid-inguinal point between the anterior superior iliac spine and the pubic symphysis. The great saphenous vein is palpated anterior to the medial malleolus. The short saphenous vein is palpated posterior to the lateral malleolus. Saphenous opening. It is a 3 to 4 cm inferolateral to medial pubic tubercle. First palpate the pubic symphysis, then go to the laterally the midline depression, then lateral to that the first prominence is known as pubic tubercle. Next is adductor canal. It is present in the mid thigh deep to the sartorius and not easily palpable. Position of the patient should be hip flexed, knee flexed and lower limb adducted and medially rotated. Next, femoral triangle. It is present below the inguinal ligament bounded by sartorius and adductor longus. Next, what are the method of palpation of the saphenous opening, femoral artery, all that, and for that we first need to palpate the pubic tubercle. Now direct palpation. Patient lies in supine position, leg is extended and slightly externally rotated. Next, use the fingertip to palpate the midline of the lower abdomen and move inferiorly. The bony prominence just lateral to the pubic symphysis is the pubic tubercle. 2.5 cm lateral to the pubic symphysis. Next is inguinal ligament tracing method. First, identify the anterior superior iliac spine. Then trace the inguinal ligament medially towards the pubic region. The medial attachment of the inguinal ligament on the pubic tubercle. So, tracing the ligament medially, we can find the pubic tubercle. Femoral artery landmark method. Identify the femoral pulse at the mid-inguinal point. We have already discussed it is midway between the anterior superior iliac spine and the pubic symphysis. Next, move your fingers medially towards the bony prominence just lateral to the symphysis. This is the pubic tubercle. Now let us discuss the claudications. What is venous claudications and what are the causes? Chronic venous insufficiency or deep vein obstruction. Example, post-thrombotic syndrome. What are the features? Pain and tightness in the calf or thigh after walking a certain distance. Worsens with prolonged standing and improves the limb elevation or walking continuously at slower speed. What is the mechanism? Impaired venous return leads to increased venous pressure, tissue congestion and pain. It is seen in case of varicose vein, deep vein thrombosis. So main concern is for us is the venous claudication. Now let us also discuss what is arterial claudication. The main cause is peripheral arterial disease, not directly due to varicose vein, but important for differential diagnosis. What are the features? Cramp-like pain, relieved by rest, no visible swelling or skin changes like venous diseases. Mechanism is atherosclerotic narrowing of the artery leading to decreased oxygen supply to muscle during activity. Neurogenic claudication. Cause is the spinal canal stenosis or nerve root compression. Feature pain, tingling or weakness in the lower back, buttocks and legs. Worsen with standing or walking, relieved by sitting or spinal relaxation, not related to vein or arteries. The clinical relevance is that can mimic leg symptoms of venous claudication, so important to differentiate. Now before going to next topic, let us summarize the claudication. In case of venous claudication, pain and tightness after walking a certain distance, worse with walking or standing. In case of arterial claudication, cramp-like pain in calf, thigh or buttocks after walking a predictable distance, relieved by rest and no visible skin change. In case of venous claudication, skin change, venous ulcer is present. In case of neurogenic claudications, the site is may be same, that is lower back, buttocks and leg, worsens with standing or walking and relieved by sitting or supine flexion. But the mechanism is different. Now what are the 5 P's associated with ischemia of limb? It is pain, pallor, pulselessness, paresthesia and paralysis. This is frequently asked in viva table. Now DVT, deep vein thrombosis. In cause, the Varicose triad is very important. It has 3 components. One is stasis, endothelial injury and hypercoagulability. All leads to deep vein thrombosis. What are the clinical signs? Swelling, pain, warmth and redness, tenderness and dilated superficial vein. Classical DVT sign. One is Homan sign. What is the method of eliciting this? Patient lies in supine with leg extended, dorsiflex the foot forcibly with keeping the knee extended. Positive sign indicates calf pain during the dorsiflexion. Moses sign. What are the methods? Compress the calf antero-posteriorly versus laterally. Positive sign indicates calf pain on anterior-posterior compression but not on lateral compression, suggests DVT. Other signs may include Lowenberg signs, Pratt's test, and phlegmatia alba dolens or cerulean dolens. Examination of varicose vein we have already discussed, so I am not going further. Now let us summarize. We have first discussed what is varicose vein. It is tortuous superficial venous system, mainly the great saphenous vein. What is the pathophysiology? There are two pathophysiology. One is perforator incompetency, and remember the level of the perforator from above downwards, that is Hunterian perforator, Dodd's perforator, Boyden's perforator, and Cockett's perforator. Next, the impotency may be present in the saphenofemoral junction. In clinical examination, we do the Trendelenburg test. In Trendelenburg test, we apply first empty the vein by elevation, then apply tourniquet. If with tourniquet it fills, indicates perforator impotency, and if without that means after removal of the tourniquet the varicosity appears, then it is saphenofemoral junction incompetency. In Perthes test, we apply tourniquet and the patient is asked to walk. In this case, the varicosity should go due to cuff pump, but if it remains, then it is perforator incompetency or DVT may be present. In Fagan's test, first discuss, let us, what is tap test or Schwartz test. In this test, we tap the site of varicosity and the impulse is felt proximal to it. If it gives positive, then it indicates impotency of the perforators. In Fagan's test, we first mark the site of the perforators, then we apply deep pressure. If the ballooning goes, then the perforators are incompetent, and if it remains, the perforators are intact. Investigations mainly radiological. Next, what is cuff pump? It is the gastrocnemius muscle. We have discussed the course of the long saphenous nerve. What is the femoral triangle, its boundary and contents? Mainly four contents: nerve, artery, vein, and the lymph nodes. The lymph nodes are the main contents of the femoral canal. These are known as the lymph node of Cloquet. Now we have also discussed the adductor canal. What are the methods of palpation of the femoral pulse? It is mainly palpated with the help of first palpating the pubic tubercle. There are few methods like direct palpation medially, first elevation felt from the pubic symphysis, or it can be traced from lateral to medial along the course of the inguinal ligament. Now, what are the three types of claudications? These are venous claudications, arterial claudications, and neurogenic claudications. The venous claudications are present in case of varicose vein. Thank you for your patience. For notes, I will give the link of my Telegram channel. You can get these notes from there. Thank you.